Great. Thank you so much, Abhay. I have very strong links with the Glasgow College, having taken my first fellowship there, and also through the Hunterian Society, of which I was the president, having hosted the curator of the Hunterian Museum at the University of Glasgow. About 2 years ago, the then Secretary of State for Health, Jeremy Hunt, commissioned this review called the Topol Review. And you will see he was looking at what the future holds from 2020 to 2040. And here are the 10 things which the Topol Review highlighted, some of which are already state of the art, such as telemedicine and smartphone apps. Virtual and augmented reality, we are just at the tip. AI, I will speak about. Robotics, of course, we have had nearly 30 years of history. And then finishing up with writing the genome, which I think is the most difficult thing to do, but is about to go big time because of an important event right at the end of 2020. So the first thing which is here and which Mihir will speak about more is robotics. For many of you who are not accustomed to what this is, it is not a big cut, but here is a surgeon, he or she, sitting with his or her head buried inside a console, which is called the Da Vinci Xi, controlling these 4 tiny little robotic arms. These are little wrists with no tremor, 7 millimeters in size, literally driving a car with his hands and feet and doing minimally invasive surgery. No tremors, the view is magnified at least 10 times. If you look at what has happened to the UK, this is what I call the legacy. When I started 17 years ago, the number of prostate cancer operations, radical prostatectomy performed robotically was 1%. Today, that has become 90%. So over a 20-year period, this is a complete transformation in the United Kingdom. But does this mean that robotics is necessarily better? I put your focus onto 3 randomized trials. The first was published in The Lancet. It's the only trial comparing open and robotic radical prostatectomy, showing no difference in continence and erections. The second is our own trial, cystectomy, open, robotic, and laparoscopic. It's the only such 3-arm trial. It had complications at 90 days as the primary outcome. No difference again between the 3 arms. And finally, the RAZOR trial in 15 centers in the United States comparing open and robotic cystectomy, again showing no difference. You could say the trials were all measuring the wrong outcome if we had powered them to blood loss, or if we had powered them to pain, then robotics would have been better. But is that really what matters to patients? So the one thing that I want you to remember from these trials is they have shown that robotics is no inferior to open surgery. In fact, we have just published the 5-year outcomes of the CORAL trial, showing, thank goodness, that the cancer outcomes are equivalent. Otherwise, you'd have had to stop robotic surgery. But it also shows that outcomes of this kind of surgery depends on the surgeon and not just on the technology. So my first punchline for you this evening is: a fool with a tool is still a fool. Focus on the surgeon, not just on the technology. Look, this is orthopedic surgery. Why just worry about prostate cancer, bladder cancer, lung cancer? What about orthopedics? This is a variety of robots that are used in orthopedics. Here is a recent review which was published. And with robotic knee surgery, you have shorter inpatient stay, less inpatient pain. But again, if you critically look at the literature, it lacks long-term data and is more expensive than traditional open surgery. So yes, we can all get very excited about digitizing those images, but a word of caution: we do not necessarily have the long-term data yet. The one thing that has happened in the augmented reality world is a group of people within the UK called the National Clinical Entrepreneurship Program. It is chaired by Tony Young from Southend. Tony was my trainee 16 years ago. I'm very proud of what he has achieved with doctors, nurses, and other healthcare individuals starting their own companies. This is one started by Nadine Hakach Haram, who is a colleague and a plastic surgeon. It's called Proximy, and it literally transports a surgeon from anywhere on earth to an operating room because you can see his or her hands and voice. This is a colonoscopy where a remote surgeon is pointing to where the problem is. In fact, the surgeon in this case might have missed this, but you can then do what is called surgical data science. You can use artificial intelligence to recognize this and warn the surgeon with such a device as to where the problem is. It's already been used in over 7,000 operations and installed in 35 countries. So these are some use cases. Look, this is open surgery, head and neck. The surgeon remotely from 5,000 miles away is pointing to the trainee as to where to make the incision. It has been used in colorectal surgery, both open and laparoscopic. And during COVID, this is my colleague, Archana Fernando, who was mentored from Seattle to do a supine robotic retroperitoneal lymph node dissection by a surgeon, Jim Porter, in Seattle. The only problem was Jim was sitting in his pajamas at 2 a.m. while Archie was sitting in London doing this operation. This featured in Sky News and The Times. The next thing I wanted to talk about is connectivity. It is great to have these technologies, but what about connecting the surgeons? Today, thank God, the internet is working, but I put to you a new term which is called Internet of Skills. What does this mean? The human brain can cope with 10 milliseconds of delay. If you then increase the distance from London to Paris, the delay increases. And if you are from London to LA, Mihir is in LA, this distance is almost inconceivable, and a bad line can really stitch you up. So the solution we have found at King's is to use 5G softwareized networks and then to shrink the distance further by artificial intelligence. So we are already in our lab thinking of 6G. We have gone beyond 5G, but this is a major piece of work that we have been doing over the last 4 years with Ericsson. So what we have done is take the vision of the surgeon, used a glove called the neurodigital haptic glove, whereby you can feel inside a patient without making an incision. We have used these little tools which are 3D printed and have haptics, and then we have used real-time slicing using 5G. And the first such 5G operation was done by me in 2018 on Facebook Live, and then lo and behold, a year later, the first 5G remote hepatobiliary surgery was performed in China. So this is very, very exciting. And as I said, in our lab, we are already thinking of 6G. Now, Abhay mentioned artificial intelligence. This is something that I've loved. I have trained myself with Google AI and various other courses that one does. So imagine you go to a remote part of the world where you do not really know what the sign means. You put your phone in front of it. It just tells you danger, cliff ahead. AI just saved your life. So AI has to be for everyone. So part of AI is called machine learning. And in very simple terms, you need to think about it as using data to answer questions. So machine learning is very simple. It is using data to answer questions. There are 7 steps to it. If you are to use data, then you have to gather it. You cannot have jumbled data. You have to prepare it. And then you have to choose a model to differentiate that data. For example, say you're trying to differentiate between beer and wine by the color. You have to choose a model which can differentiate between the 2 different colors. Then you train the model with 80% of the data. For example, if you had 1,000 patients, you use 800 to train the data, and then the other 200, which is 20%, you use for evaluating that model. The model will not get it right first time, so you then tune it, which is called parameter tuning, and finally the seventh step, which is output prediction. So Andrew Hung from Mihir's department, along with Inderveer Gill, has been leading the world in using machine learning to develop what is called automated performance metrics. And this is to see how a surgeon performs and apply it to clinical outcomes. So here is a robotic operation, prostatectomy going on. This is a video. You put it through a black box and you get two bits of information. One is the movement of the instruments, which is called kinematic data, and the second is system events. And you put it all together quite simply to get automated performance metrics. So you would think, based on what Tim has said, with centralization, the highest volume surgeons here, the first 4 surgeons, would have the best outcome. Surely these are the less experienced surgeons. But look at how automated performance metrics by machine learning measures these surgeons. Surgeon 1 does have the best outcomes as regards continence. Surgeon 2 is not as good. Surgeon 3 is somewhere there. Surgeon 4 is in between. But here is Surgeon 5, who is naturally talented despite not having the highest volumes. Likewise, Surgeon 6, 7, and 8. So the machine sees things and predicts things differently. And I think this would be very important for the future of training of the next generation of surgeons. AI can also be used to predict images and cancers. This is Jiva AI. This is another entrepreneurship program company that I work with. It can predict prostate cancer and take away the variability between radiologists with 90% accuracy. But here is the good news. You can then take that image, that flat image from an MRI or a CT scan, you can automatically volumize it so that it becomes a 3D image. And then you press a button. In this case, this is an image of the heart, and you get a 3D print, and you press a button, and overnight it'll 3D print the organ for you. This has been used in transplantation to plan pediatric transplants for kids. This is robotic prostatectomy. This is a T3 tumor. It's literally bulging out of the capsule of the prostate. It is 1 millimeter from the sphincter. And we have shown that by 3D printing the prostate, you can reduce positive surgical margins in cancers that are peeping out of the capsule from 35%, which is what we used to accept somehow, to 10%. So this is absolutely game-changing, and I think holds a future in the place of digital surgery. What about COVID? Well, we have developed an app within King's, which is called the Zoe App. It has already been published in Nature Medicine. And here we have been interrogating this app to see if blockers of TMPRSS2, which is present in the prostate, can actually reduce the severity of COVID. So this is a paper we published at the end of last year. This is a cell membrane. This is the ACE2 receptor from the kidney. This is where the virus attaches with its spike proteins. And underneath it is TMPRSS2, which is found in nearly 3/4 of prostate cancers. Can we block it with dutasteride or finasteride? And the answer is yes. And this is again an example of digitization of information. Well, one of the press people from a newspaper called The Telegraph got hold of what I was doing with automation. During COVID, we got a major grant from the Engineering and Physical Research Council, or EPSRC, worth nearly 12 million, called Trustworthy Autonomous Systems. And they asked me saying, Prof, do you think now that nearly 30 million operations are waiting, you could sit in a room and guide a robot to increase your capability and start operating autonomously in different rooms? And I said, look, there are certain things a robot can do better than a human being, which is suturing. This has already been published 4 years ago in Science Translational Medicine. But the robot cannot think like a human being. So this is just science fiction. You still need the judgment of a surgeon. And thankfully, they listened to me and put out this cartoon of a rather surprised surgeon trying to see a robot doing automatic things. Finally, I said I would talk about a change that has happened in reading the genome. Let me tell you about this. Imagine this is a cancer cell, this is the DNA, and this is the target sequence that has gone wrong. You can introduce a guide RNA, which then binds to this target sequence. You can then have an enzyme which goes in called Cas9, which binds to the guide RNA. It then slices the damaged segment, the target sequence here, and attaches the correct sequence. This is called CRISPR Cas9. And I mentioned this to you because at the end of last year, Doudna and Charpentier won the Nobel Prize for this research, which is going to change, I think, the future of the way we think. If I was a young researcher today, I would give a lot of attention to the work of these two ladies, and I would certainly invest in this. In fact, I have already hired one of the best CRISPR-Cas scientists into my own lab at King's. Finally, a word for the trainees. While all this is ongoing, we have been doing a lot of simulation. In fact, over the last 10 years, we have been running a randomized controlled trial through BAUS, which is the first and only randomized controlled trial of 1,140 patients worldwide who are randomized to either having simulation-based training versus no simulation-based training. And these trainees who are operating on the patients were followed up to see if they perform better. This trial is called Simulate. It is just about to be published, and it shows for the first time that simulation can actually create safer surgeons and have better patient outcomes. So I think the future is bright. I think we should invest heavily in simulation in a digital future for surgery. So Abhay, thank you again for having me. It's a great pleasure to address the webinar online. Thank you so much.
So the first one is a very practical question, which says, do you think that the new ways of working will create a significant generation gap amongst the doctors involved? It's probably a little bit philosophical, but you know.
I don't think so. The generation gap is in your head. I tell you why. Mani Menon, probably the world's most distinguished robotic surgeon, started doing his Da Vinci procedures 20 years ago at the age of 56. So if he could, then anyone can. I think the generation gap is entirely in your head. As long as you can sort your head out, you can do whatever you wish.
Good point, Prokar. Thank you for that. There's a practical question, which is, I think it's a very important question. So the question is about systems such as Proximie. Who is responsible for consenting the patient? Is it the surgeon who is actually being guided, or if it is being guided by a remote surgeon and have not yet performed that procedure, then who should consent the patient?
So the surgeon who is there with the patient has to record the consent, has to tell them what is happening, and then has to file that in the notes. It has to be made very clear that none of that patient data is made public. Proximie and any other such platform, and there are a few others, are all HIPAA and GDPR compliant. So you have to follow the regulations. You cannot just share this data and breach the consent with the patient. So the surgeon is responsible.
Surgeon's finally responsible, which makes perfect sense. I suppose the last slide that you put up has kind of got the juniors interested in how do they get involved in any of these projects, is the question.
So there are national surgical simulation programs. The editor-in-chief of surgical endoscopy has a national laparoscopic program, but I think the way to deliver it is locally. Almost every education center has a human factors site. Talk to your anesthetist, talk to your A&E consultants, and even if you don't have access to this, have a shoebox at home, make 2 holes in it, put 2 instruments through it, make a hole in the corner, put your iPad on it, record your operation, take it to your chief and say, can I please improve? And he or she can score you from home. You don't even have to go to a lab. And then you can continue doing that every week till you improve. So it's not just very expensive, and we have a £3 million simulation center, a virtual hospital, but you can do it for peanuts just at home if that's what you wish to do. It has to be delivered locally.
Okay. Is there any place the juniors can approach, like their deaneries, etc.? Are they involved?
Yes, yes. So although deanery funding has been uh, going down in the last 10 years, unfortunately, all these programs were heavily funded in London by the deaneries, which are now combined London North and South and going right up to the South Coast. That money is fading. So absolutely ask your deanery, your head of school, for example. If you are within a university, there will be a head of school who will have a funding pot. But as I said, even if you don't have any money, a box with two holes, two sticks, and your iPhone or iPad is enough. You don't need money to do this. You just need your mind, and you need to have the right innovation to be able to solve this problem.